Hello, my name is Catherine Naber, and I am here to present our project using ultrasound to assess diaphragmatic atrophy over time in mechanically ventilated pediatric patients after laryngotracheal reconstruction. We know that diaphragmatic atrophy prolongs duration of mechanical ventilation in adults. Sepsis and neuromuscular blockade worsen diaphragmatic atrophy. It is present in mechanically ventilated children. However, previous studies have not controlled for the effect of sepsis and neuromuscular blockade. The effect of diaphragmatic atrophy on duration of mechanical ventilation in children is still unknown. We are conducting a prospective observational study using ultrasound to determine the effect of mechanical ventilation with neuromuscular blockade on diaphragmatic atrophy and the time course to its resolution in children after laryngotracheal reconstruction surgery. We measured diaphragmatic atrophy in mechanically ventilated patients under neuromuscular blockade using an ultrasound with a linear probe in B mode and tracing down the mid-axillary line to the zone of apposition, as seen in the upper right-hand corner. We then visualize both the pleural and the peritoneal line under ultrasound, as seen in the lower right-hand corner, and measure the distance between these two lines at both inspiration and expiration. We also calculate the diaphragmatic thickening fraction, which is another measure of diaphragmatic atrophy and diaphragmatic dysfunction. It is defined as the percentage of increase in thickness of the diaphragm during inspiration and is calculated by the formula below. No normal values exist in children. However, in adult patients, a diaphragmatic thickening fraction less than 20% is indicative of diaphragmatic atrophy and dysfunction. We have enrolled 5 patients in our study thus far and have collected diaphragmatic thickness measurements on 3 patients after laryngotracheal reconstruction. Our first patient, a 19-month-old female, had diaphragmatic thickness measurements that increased over time but returned back to baseline by postoperative day 15. The diaphragmatic thickness measurements of our second patient, an 8-year-old male, actually increased over time, while our third patient, a 21-month-old female, had diaphragmatic thickness measurements that decreased over time. This is a video showing the very slight increase in diaphragmatic thickness with inspiration in one of our patients. These are still images that show how we measure the diaphragmatic thickness at inspiration and expiration in our study. Our preliminary conclusions are that the effect of prolonged mechanical ventilation with neuromuscular blockade on diaphragmatic thickness remains unclear and more data is needed. Additional patient enrollment is anticipated in the coming months. Ventilator settings, as well as degree and duration of neuromuscular blockade, may affect diaphragmatic thickness in this patient population. Understanding the time course of development and resolution of diaphragmatic atrophy may help mitigate the duration of mechanical ventilation and hopefully prevent reintubation due to muscle weakness in future patients. Thank you very much.